Hello and welcome back to the pre-work video series for Improvement Facilitator Training for Opioid Process Improvement. This is the second video in the series, and it will provide you with some background information on the opioid crisis in Alberta, which can help to engage primary care teams in the opioid process improvement work. As you know, Alberta and the rest of Canada and beyond are in the midst of an opioid crisis. According to the CPSA, the College of Physicians and Surgeons of Alberta, Canada has the second highest prescription opioid use per capita, and Alberta has the highest consumption of all provinces. Opioids have been used for pain management for thousands of years, and in the 17th and 18th centuries, physicians used laudanum, which was a combination of alcohol and opium, as a common remedy. In the 1800s, morphine was isolated from opium, and it became the preferred treatment for pain, anxiety, and other ailments. In the 19th century, a morphine and alcohol syrup called A Mother's Kiss, Mrs. Winslow's Soothing Syrup, was marketed for helping children to sleep, if you can believe it. Synthetic opioids like oxycodone were introduced in the 1950s, and doctors quickly embraced them as a treatment for pain. During the 1980s, physicians explored the use of prescription opioids to treat cases of chronic pain. The prescription opioid landscape changed again in the 1990s as new slow-release opioids entered the market, and these offered pain treatment options that were supposed to be safer. In the 1990s, aggressive marketing of drugs like OxyContin encouraged physicians to do a better job of managing patients' pain by prescribing opioids, which were believed to be safe and non-addictive. Now, of course, we know differently, and we're asking physicians to change their prescribing behavior. So we want to be clear that although prescription opioid use has become problematic, no one is telling doctors to stop prescribing them completely. Opioids are powerful drugs, but they still have their place in pain management. Primary care just needs some processes around ensuring their safe and appropriate use. Now, many people believe that those who are dying from opioids are not the typical people being cared for in primary care, and that it's not a primary care problem. So who is the face of the opioid crisis? We're going to take a look at the demographics of Albertans who are most affected by this crisis. And luckily, Alberta has the most accurate data in the country, as the Ministry of Health tracks various factors related to opioid use, including emergency department visits, prescription dispensing, and death information. And the information on deaths are acquired through the Office of the Chief Medical Examiner, and they're reported quarterly. So these stats show that of the illicit opioid deaths, 79% were young males, which one might expect. But if we look at the non-illicit opioid deaths, or what we would think of as prescription opioid deaths, there was an even split between the genders and an even distribution of ages. And further to that point, we can see from the 2016-17 stats that 55% of opioid-related deaths, both illicit and non-illicit, occurred in people aged 20 to 39, with the highest instances being those in the 30 to 34-year-old range. While that age group may be expected to have the highest incidence, notice that 45% of opioid-related deaths occurred in people over age 39. So it might surprise you who could be affected by this public health crisis. From the stats collected, we see opportunity. Of the opioid-related deaths in Alberta in 2017-18, 67% of those who died had received their opioid from a community pharmacy within the previous month. From this, we know that these patients had a prescription for opioids and were therefore interacting in the healthcare system. This interaction provides us an opportunity to start having a different conversation with patients from the time of initial prescription or prescription renewal. In response to the crisis, we saw updated guidelines come out from the Centers for Disease Control in the US and the Canadian Opioid Guideline for Chronic Non-Cancer Pain in Canada to provide some guidance around prescribing of opioids. In the US, policies have been created that were misapplied the CDC guidelines, and that's led physicians to be scared of prescribing opioids at all. While Canada has not legislated those strict policies, Canadian doctors who follow what's happening in the US may feel resistant to new guidelines. In addition, over the past few years, the College of Physicians and Surgeons of Alberta came out with a new standard of practice around prescribing medications with potential for misuse or diversion, such as opioids or benzodiazepines. The standard of practice outlines rules and recommendations to be followed in order to protect the public and in turn the physicians prescribing these medications. With this, the CPSA sent a letter to all physicians who prescribed opioids, highlighting instances of high use as a way to bring about awareness. This letter, called the MD Snapshot, was meant to be a non-punitive, non-judgmental tool that could be used for quality improvement. So this slide outlines what is included in that MD Snapshot. So specifically, it includes the number of patients to whom you prescribed opioids, the total OME per day prescribed, the average OME per day per patient, the number of patients receiving one or more opioid and one or more benzodiazepine prescribed by you, the number of patients receiving opioids at an average dose of greater or equal to 90 OME per day, the number of patients receiving 3 or more opioid ingredients, and the number of patients receiving opioids from 3 or more prescribers. You can see a sample MD Snapshot report on our website. The snapshot includes individual physician data as well as a comparator group from their specialty. Now, this is interesting. When illicit and non-illicit opioid-related deaths are tracked over time, we noticed what we believe may be a correlation before and after the CPSA standard change. So again, I want to preface this by saying that the trends are observed correlations only, and we can't draw any any conclusions about causation. But we did notice that there was a decrease in non-illicit or prescription opioid-related deaths after the CPSA standard changed after the third quarter in 2016. And additionally, there was an increase in the number of illicit opioid-related deaths after the CPSA standard change. One could interpret this as more patients turning to illicit opioids as a way to replace their previously prescribed opioids. However, we can't know if that's just coincidence, but it is something to think about. When we think about opioid-related deaths, who thinks the deaths are occurring in the downtown core? Well, one might assume that this is a downtown/urban problem. By far, the majority of deaths did not occur in the urban core. In fact, in Calgary, 88% of the deaths occurred outside the downtown core, and similarly in Edmonton, about 80% of deaths occurred outside the downtown urban core. In 2017, in the Calgary zone, there were 224 opioid-related deaths. If we look at the 2 red zones, which actually represent more than the true downtown core, they account for about 30% of the opioid-related deaths. So 70% or more of the opioid-related deaths occurred outside of the downtown core last year. Edmonton was similar. There were fewer opioid-related deaths, but also the majority occurred outside of the downtown core. And finally, we can see that 56% and 51% of deaths occurred at the patient's home address. This creates an opportunity for primary care in the promotion and distribution of take-home naloxone kits. Let's put a face to these patients and note that this is a true story that happened in Alberta. This is Phil. He's a 50-year-old self-employed plumber who's been struggling with degenerative arthritis in his knee. He's a heavy smoker and he self-reports moderate drinking. He's been trying to put off the knee replacement surgery for as long as possible, but his knee has become a major issue for work. Plus, he really wants to be able to dance at his daughter's wedding that's coming up in the summer. He's been referred to a local orthopedic surgeon for knee replacement surgery, and he receives that surgical date, but the family physician office has not been made aware of that. So Phil has his knee surgery, and he's discharged on the second day with a few Tylenol 3s and anti-inflammatories. He's also given a booklet with instructions for exercises and self-management. He has a follow-up appointment booked in 2 weeks with the nurse. But the T3s don't do much to control his pain. He struggles to hang on knowing he has an appointment with the nurse. And at that 2-week follow-up appointment, Phil sees the RN at the surgery clinic who removes his staples and assesses his knee and advises him to see his family doctor to talk about pain control. Shortly after, though, Phil sees his cousin who offers him some leftover Percocet that he had from oral surgery. The Percocet works much better for Phil, and he takes it at the maximum label dosage described, which was 2 pills every 4 hours. Now, before he can see his family doctor, he has to fly across the country to his childhood hometown to attend a funeral. And while he's there, he runs out of the Percocet that his cousin had given him. But one of Phil's old friends connects him with a guy who hooks him up with some illicit Percocet. And unfortunately, those Percocet pills were laced with fentanyl, and Phil accidentally overdoses. When his family doctor receives notice that Phil has died due to an overdose, she is completely shocked and bewildered. She didn't even know that he'd had his knee surgery. So, we know in primary care that there are many competing priorities, and it's difficult to divert time and resources to supporting a small group of patients. We know that some family practices may only have a handful of patients who are taking opioids. However, when we compare the number of deaths in the province that are opioid-related compared to those who died of influenza, we see a huge discrepancy. There were 687 deaths due to opioids compared to 84 due to influenza, and we put a lot of resources into influenza prevention and management each year. Additionally, if we take a look at the numbers, not just in terms of deaths, but in potential years of life lost, it's a dramatic difference. Over 9,000 potential years of life lost due to opioids compared to just under 600 due to influenza. So if we applied the effort and focus that we do to influenza to opioids, imagine the impact we could have. So far, we've focused on the patients who have died because of opioids. However, we know that there are many, many people living with opioids. Specifically, 1/3 of Alberta patients report that they or another member of their household have spoken to a physician within the last year about using an opioid to manage pain. 1/4 of Alberta patients report that someone in their household has received an opioid prescription within the last year. 51% reported that a second prescription was required for their condition. And 1/3 did not finish the entire first prescription. That third of prescriptions that go unfinished have the potential to cause additional harm should they be lent out, like in the case of Phil, or if discovered or consumed by someone who is opioid naive, like a teenager. The evidence tells us that primary care is part of the solution in terms of preventing opioid-related deaths and supporting those who are living with opioids. The peer group has found that opioid agonist therapy rates are higher when they are introduced by primary care as opposed to specialty care. Specifically, an additional 1 in 6 patients will be retained in therapy. Additionally, patients are more satisfied when they're treated in their medical home as opposed to in specialty care. As mentioned before, improvement facilitators do not need to be opioid content experts. Rather, IFs can support physicians and teams with process improvements that will help to improve the patient experience, identify patients taking opioids who are on a panel, optimize care management with prescribing, and help to coordinate the care within the medical home and the health neighborhood. On our website, you'll find guiding principles. This document outlines what we've covered so far today, and it also includes some language that might help when you're engaging with teams. And as we close, I want to take a different look at Phil, a different outcome. Had his team been there to support him with process improvements that would have allowed them to stay connected with him through his care? So before his surgery, Phil's family doctor meets with him to do some assessments. Phil has a higher risk of OUD, so she confers with the surgeon about a plan. Phil has his surgery as before and is discharged, only this time a discharge summary is sent to the family doctor. As previously, Phil experiences uncontrolled pain. However, his family doctor's nurse calls to check up on him as per their clinic protocol. This time, he sees his family doctor and they decide upon a controlled dose of Percocet with a 2-week plan to taper off. His doctor sends a note to the orthopedic team to keep them up to date. When Phil sees the RN for his 2-week post-op appointment, this time they have an in-depth discussion about non-prescription options for managing pain. When Phil finds out he needs to fly across the country to the funeral, he contacts his family doctor. They have a brief phone discussion and come up with a contingency plan in case his pain gets worse. In this scenario, Phil is able to work with his team to follow a taper plan, and his life goes on, and he's able to dance with his daughter at her wedding that summer. So before we meet again at our training, We wanted to give you some things to think about, some questions to reflect upon. So, what surprised you about the Alberta opioid crisis? What didn't surprise you about the opioid crisis? What were your key takeaway messages from this presentation? As an improvement facilitator, how might you use this information with teams? What do you still need to know or know more about? And any other thoughts that you might have. So there's one video left for you to watch in the series in preparation for training. Thanks again for joining, and we look forward to seeing you soon.